Thanks, Julipal. Okay, just want to say hello and welcome to everybody for our December webinar. This is our last webinar of the fall semester, as hard as it is to believe that. Before I introduce our speaker for tonight, I just have a couple quick announcements. On December 21st is second announcement is there is going to be no webinar in January. It's probably going to be well, no, it's not New Year's Eve, but it's going to be before the semester starts. So no January webinar, and we are going to pick back up in February, the first weekend or the first Wednesday of February, February 2nd. And as of right now, it looks like we're going to have one of our former students come speak, which we're really excited about. So without any further ado, I am going to, well, I know our speaker tonight has a little bit of her bio in her slides, so I don't want to steal any of her thunder. So tonight's talk is going to be about public health preparedness for highly infectious disease. And our speaker is Lindsay Burkheiser, and she is new to Penn State, and I'm really excited that she is going to be speaking with us. So Lindsay, I'll turn it over to you.
Thank you very much. Hi, everybody. Thanks so much for joining me tonight. I'm really excited to be here. I actually do have some slides that I'm going to share with you. So let me pull this presentation up and we'll get started tonight. Okay. Is everybody able to see that? I see thumbs up. All right. Perfect. So, again, my name is Lindsay Burkheiser, and I'm going to be talking to you today about public health preparedness for highly infectious diseases. I will ask that those of you that have questions, save them for the end of the presentation. You're welcome to either raise your hand or enter them in the chat, and I will open the floor then to your questions. So I am the Highly Infectious Disease Program Manager for Penn State Milton S. Hershey Medical Center, and I'm very excited to be able to be here with you today. For those of you who had an opportunity to read my bio, you'll remember that I started my career as a registered nurse. I spent several years at the bedside, and I even took some travel contracts to explore other healthcare systems. I had dabbled in various specialties, but I never quite found the right fit. So I went back to school, continued my education. I finished my bachelor's in nursing, and then again to start a master's degree program also in nursing. By this point, I had taken a job as the director of clinical services, had oversight of a few nursing units that I had practiced in myself, and I had taken on additional responsibilities as the campus emergency manager, which was kind of an other duties as assigned kind of role, but really ended up shaping my future then. Prior to the pandemic, I was involved in various hospital preparedness activities related to workplace violence, emergency response plans, some other topics. But when COVID hit, it really reignited a long-held interest of mine in highly infectious disease. So my experience working in the pandemic, writing policies as we were, working in the field, testing procedures as we went, really solidified my desire to study and work in healthcare system preparedness. So here I am. And my role for the healthcare system is to manage and grow the highly infectious disease program, which was born out of preparedness efforts related to the Ebola outbreak from 2014 to 2016. Hershey Medical Center was actually the recipient of grant funds from the Pennsylvania Department of Health to update critical infrastructure, retrofit isolation spaces, develop curriculum, train staff, and purchase specialized equipment and supplies to bolster our capabilities to manage patients infected with highly infectious diseases. The Special Pathogens team was created from volunteer staff, interdisciplinary staff from all areas, and trained extensively for the potential to treat an Ebola patient. Their efforts were rewarded when the hospital received their status as a designated Ebola treatment center something that only 8 hospitals in the state of Pennsylvania can claim. But now recent events have highlighted the need to broaden our focus and enhance our capabilities to manage other highly infectious disease scenarios that we may face as healthcare workers, leaders, and public health professionals. So what exactly is a highly infectious disease? Highly infectious diseases have a combination of 3 primary characteristics: infectiousness, contagiousness, and hazard. As you can see, Ebola falls in the center of this diagram. It's truly a triple threat pathogen, demonstrating all 3 of these characteristics in abundance. Also shown here is the relative contagiousness of respiratory-borne illnesses such as SARS-CoV-2, otherwise known as COVID-19. These characteristics are important when evaluating the potential impact of a new pathogen on the healthcare system. For example, when looking at infectiousness, you can see here that the microbial burden required to infect the exposed host varies greatly depending on the infectiousness of the pathogen. So while one must be exposed to 1,000 viral particles of the flu in order to become actively infected, it takes only 1 particle of the Ebola virus to cause disease. As we saw over the last year and a half with the COVID-19 virus, contagiousness of a pathogen has the potential to have devastating consequences on community spread and patient surge. While infection with the Ebola virus requires direct contact with bodily fluids, a disease that spreads through airborne particles has the potential to infect as many as 12 to 18 people from just 1 infected individual. Studies have determined that SARS-CoV-2 appears to be comparable to SARS, infecting 1.4 to 6.1 individuals for every sick person, depending on the strain. The likelihood of the pathogen to cause significant illness or even death is described as its level of hazard. Because of Ebola's mortality rate, it is considered to be an extremely hazardous pathogen. While COVID-19, fortunately, did not demonstrate the level of lethality anywhere near that of Ebola, it did require extensive care and intervention, as well as resulted in increased lengths of stay for some of the more critically ill patients. Although not all pathogens possess all 3 of these characteristics in the abundance that Ebola does, preparation is still important to ensure that the organization can withstand the challenges presented by each unique organism. So where do highly infectious diseases come from? One primary source is zoonosis. Zoonotic diseases account for 75% of all new or emerging infectious diseases, according to the CDC. The WHO also reported that more than 30 new pathogens capable of infecting humans have been discovered over the last 3 decades, and that these diseases caused by these emergent pathogens often cause explosive outbreaks with high mortality rates among the affected population. Pathogens spread from animals to people through direct contact, such as handling animals, meat, and waste, indirect contact, including contaminated areas such as pens, coops, and habitats, vectors, including a variety of pests like mosquitoes and ticks that bite both humans and animals, foodborne sources like unpasteurized products or unwashed fruits and vegetables that are contaminated with animal waste, or through water that has been contaminated by the waste or remains of a diseased animal. So let's talk about some factors that influence zoonosis, such as urbanization. Humankind is rapidly expanding and developing regions that were previously uninhabited. And in this process, they are encountering more variety and volume of plant and animal species. Additionally, there has been a shifting trend in the number of people living in urban areas. As a matter of fact, over half of the world population lives in urban centers. Africa and Asia, 2 very densely populated continents that are still significantly impacted by infectious disease, expect to see a significant increase in the number of people residing in an urban setting, perpetuating the need to expand those urban areas even further. This is very concerning, as a dense population is more susceptible to disease transmission, and challenges in urban planning and healthcare infrastructure could result in poor drainage, inadequate housing, and a slew of other hazards that could exacerbate this fact, such as drawing pests and rodents, for example, which could be vectors for disease. Travel, livestock movement, and trade all amplify the risk to other nations, as a disease outbreak in one country is really only a plane ride away from spreading across the globe. So as you can see here, the population of Asia and Africa are increasing at a much more rapid rate than the population of other nations. This exponential population growth will result in a greater population density, urbanization of once rural areas, and more wildland development. And this is very problematic, as over 400 new species of animals have been discovered since only 1993, with the majority of those being found in Africa and South America. As wildland continues to face deforestation and development, people will continue to be exposed to more and more unique species. So not only does the increasing presence of humans influence zoonotic disease, but human behavior has also historically had a very significant impact on the evolution of emerging infections. And this holds true for agricultural practices. Increasing herd sizes to meet growing demands for food and for the expanding population also increases disease transmission among animals. Oftentimes, these illnesses have a broad host range, meaning that they can easily spread from livestock to the people who tend to them. Livestock can also function as an amplifier host, meaning that the pathogen has the opportunity to evolve and spill into human hosts when it previously would not have been able to cross species. The need for livestock movement across national borders has the potential to introduce new pathogens to naive populations, making them more susceptible to infection and increasing the risk of outbreaks. And similarly to the encroachment of the human population into undeveloped habitat, the increasing interactions between livestock and wildlife as a result of rapid development of land for agricultural purposes bridges the gap between the transmission of novel viruses in the environment from wildlife to people. This diagram shows how cases of a naturally occurring illness wax and wane in the wild animal population until such a time where there is a spillover event from that species into a domesticated animal population. During the amplification phase, the pathogen has the ability to spread in this new species unencumbered by the natural immunity derived from previous exposure. While undergoing rapid replication, the pathogen mutates to evolve new traits, including the ability to spill over once again, but this time into the human population. If any of those newly evolved traits also support human-to-human transmission, isolated cases can quickly multiply into an outbreak. You may also notice on this diagram that there are several points indicated as control opportunities. This means that intervention at these points in the cycle can help to prevent the spillover events that spread pathogens from one species into the next. Control opportunities can be identified through population and case-based surveillance, or the monitoring of species that serve as a reservoir for the disease and following individually identified cases in people. Early recognition and implementation of control measures to prevent the continued spread of the illness will influence the ability of the pathogen to cause an outbreak in the human population. As a result of the need to develop land to support the growing human population, agricultural and economic needs, deforestation in South America, Asia, and Africa contributes significantly to exposing people to new animal species and therefore more novel pathogens. In addition to direct contact during the process of deforestation, the displacement of animals as a result of this work has the potential to carry pathogens far and wide to new regions that otherwise would not have been exposed to that disease. This was the case with the Nipah virus, which resulted from fruit bats being displaced to other regions as forest was removed for land development purposes, thus eliminating their food source. As you can see here, there is significant deforestation activity in South America, Africa, and Asia. The green represents current forest area, with the gray portions demonstrating land that has been deforested in the time period from 2004 to 2017. The total area is roughly the size of Morocco. The pink areas are regions that are currently experiencing significant deforestation activity. And as you can see, they are widespread across several continents. The global wildlife trade for recreational purposes is even more dangerous than traditional agriculture in some respects. That's because a lot of this activity is illegal, is carried out covertly, and there's little regulation to promote sanitation or safety practices. The act of hunting, trapping, and butchering wildlife puts hunters at risk of exposure, not only from direct animal contact, but also from indirect contact with the contaminated environment that they're entering. Monkeypox, Ebola, and HIV transmission have all been linked to the butchering of non-human primate species. A Pandora's box of RNA viruses and fungi can be found in bat feces, as bats serve as a reservoir for many zoonotic illnesses. And wet markets, which are popular in China and Southeast Asia, can also be a reservoir for disease, as freshly butchered and sometimes still live animals and animal products are sold in poorly regulated shops on the street. According to a special report from the BBC, over 420 million animals, including monkeys, reptiles, birds, and various small mammals, were sold and traded throughout 226 nations over the last 20 years. While the sale of these animals for consumption or companionship is a lucrative novelty, the fluid movement of species across borders contributes to the spread of new diseases to naive and particularly susceptible populations. This was demonstrated very well in 2003 when there was a monkeypox outbreak in Texas, which was traced back to pet prairie dogs that were sickened by African rodents prior to being imported from Ghana. This timeline highlights just a few of the most recent zoonotic diseases to hit the headlines. And although these diseases got top billing across the news entities, small outbreaks of these illnesses and others are constantly occurring across the globe. If you look at this year alone, 2021, you can see that there have already been isolated outbreaks of several diseases occurring in the background of the COVID-19 pandemic, including yellow fever, Zika, and even the plague. Some have impacted the United States, and some have remained in the regions that they're endemic to. And once again, citing monkeypox, globalization and the ease of international travel and trade can serve as a route to spread disease. The United States had not seen a case of monkeypox since that incident in 2003 until this year, when a man traveling from Nigeria landed in Texas infected with monkeypox. So what does that mean for us as healthcare workers, public health leaders, emergency preparedness staff? It means that a disease anywhere can become a problem everywhere. It's critical to maintain situational awareness of what's going on in the world and how it could ultimately impact global public health. So what's currently on the radar? Aside from the new evolving strains of COVID-19, of course, the World Health Organization has identified several diseases that currently cause outbreaks, have significant mortality or long-term health implications, and have very limited treatment and vaccination options. The list includes Ebola, Marburg, and Lassa, which are all viral hemorrhagic fevers that cause massive bleeding, multi-system organ failure, and death in 50 to 90% of those infected, depending on the strain. MERS-CoV and SARS are respiratory illnesses that have already caused multiple widespread outbreaks and have the potential to return on a larger scale. Nipah is related to measles, but can have a high mortality rate, as high as 75%, and that's a result of the encephalopathy and other severe complications of the illness. Zika, although it causes a mild illness in most adults, it causes birth defects in the fetuses of infected pregnant women and can cause latent illness in children born to women who were infected during their pregnancy. It also was very efficient in spreading across the North American continent during the outbreak in 2015, making it a potential pandemic candidate. Crimean Congo hemorrhagic fever and Rift Valley fever both predominantly affect animals, but they do spread to people with devastating consequences. Blindness, hemorrhaging, and encephalopathy cause death in 10% or greater of cases. And finally, monkeypox, which is in the same family as smallpox, but only demonstrates about a 10% case fatality rate. So after reviewing this watch list, you may be wondering why we do not see more pandemic illnesses and why we haven't seen a pandemic of one of these illnesses yet. In actuality, we've seen 4 influenza A-based pandemics in the last 100 years. The influenza division of the CDC notes the H1N1 pandemic of 1918, which was devastating, killing over 700,000 Americans. The next pandemic of 1957, which was the result of a different influenza A strain, H2N2, resulted in approximately 116,000 deaths just in the United States. The H3N2 strain in 1968 killed over 100,000 more Americans. And finally, when H1N1 reemerged again, killed another 13,000 Americans. And that's not talking about the global impact of these diseases. So what does it take to cause a pandemic? Let's first define a pandemic. According to the CDC, a pandemic is declared when a disease has spread across multiple countries and has typically infected a large number of people. For a pathogen to achieve widespread infection covering a large geographic area requires some specific traits. These traits have to support the pathogen's ability to efficiently and effectively infect hosts, spread between them, and withstand assaults from the body's immune system and therapeutic interventions. Specific characteristics must work in tandem in order for a pathogen to present a significant threat to the population and to enable its ability to evolve into a pandemic. Several studies have been conducted to identify exactly what these characteristics are and how they contribute to a pathogen's overall global catastrophic biological risk. The mode of transmission is an important factor, as many of the methods for spreading disease that we have discussed, like contact with body fluids or exposure to vectors, can easily be mitigated through simple barrier protection and hygiene practices. That is why respiratory spread illnesses are of particular concern when discussing pandemic potential. The transmissibility of the infection, particularly during the incubation period, which is the time prior to the patient showing symptoms, will provide greater opportunity for community spread, as opposed to an illness where patients are not contagious until they exhibit symptoms and therefore have less opportunity to spread disease. The susceptibility of the population to the infection is required for the pathogen to be able to find enough hosts to infect and perpetuate spread. If the population has had previous exposure to the disease or a close variation of it, natural immunity can hamper the ability of the virus to achieve pandemic status. This is why zoonotic diseases are important to monitor, as the majority of the human population is immunologically naive to these viruses. The absence of effective therapeutics and vaccinations and the ability of the pathogen to evade and defend against detection and destruction by the immune system also supports pandemic potential. Fortunately for us, it's not common for a pathogen to hit the pandemic jackpot and immediately possess all of these characteristics. However, the evolution of emerging illnesses has the potential to result in more outbreaks, sustained infection spread, and even the next possible pandemic. So what can we do to prepare for the next pandemic or serious outbreak? The diseases that we have discussed are highly variable, spread through different modes of transmission, and have very different characteristics. And as COVID-19 demonstrated, the next bug may not be something that we're expecting or that we've ever seen before. With new pathogens emerging from zoonotic sources and the expectation that people will continue to encounter new flora and fauna as the population expands into new and uncharted territory, Pandemic X could be anything from anywhere. Unlike Ebola, where the world had time to identify the threat and prepare a coordinated response to it, some of these illnesses have the potential to rapidly evolve into a pandemic, spreading inconspicuously in the community before being recognized. This was the case with COVID-19, which demonstrated similar initial symptoms as other seasonal respiratory infections. While Ebola and similar illnesses are often stopped at the third stage of this evolution, a pathogen that can achieve sustained human-to-human transmission can easily become a global pandemic if proper measures are not taken. And again, this was demonstrated by COVID-19. So let's start by identifying factors that contribute to sustained human-to-human transmission and how we can influence them to mitigate the impact of a potential threat to public health. Again, we revisit the concepts of infectiousness and contagiousness. A pathogen that requires low microbial burden to infect its host, or that is effective at producing a high viral load in its host, can significantly increase the risk of transmission. Pathogens can be transmitted between people via a number of routes, similarly to the transmission of disease from animals to people, which includes direct and indirect contact, airborne routes, vector-borne routes, and more. Knowing the method of transmission for the pathogen of concern can guide policy and practice surrounding the preparedness and response efforts of public health entities and healthcare organizations. For example, if something is spread via droplet or airborne routes, small, crowded, poorly ventilated spaces will increase transmission, increasing the vulnerability of people in densely populated areas using communal resources like shopping centers and schools. The seasonal flu, colds, and COVID-19 are pathogens that spread this way. For a pathogen that spreads by direct contact with patients or their bodily fluids, or by fomites, which are objects that can carry infectious particles like doorknobs and cell phones, sanitation practices and the management of patients and the deceased will impact further community spread. This is the case in Ebola outbreaks, where many medical and decedent care personnel are infected due to a lack of proper sanitation, burial practices, and personal protective equipment. An illness that is spread primarily through vectors, or a parasitic animal like a flea or mosquito that transmits disease both from animals to humans and humans to humans, the elimination of that vector or minimizing exposure to that vector will reduce the spread of the disease. Mosquito-borne diseases like malaria are a prime example of this. The use of mosquito nets and insect repellent helps reduce cases. Understanding what pathogens are emerging and how they are evolving is important for public health professionals and leaders to be able to guide preparedness, response, and recovery efforts in the event of future outbreaks. The use of non-pharmaceutical interventions or community mitigation strategies is an important component of early response efforts in lieu of the development or availability of vaccinations and therapeutics. These measures seek to minimize human-to-human transmission through behavioral and social changes. While the nation maintains a strategic national stockpile of specialized supplies and equipment, including personal protective equipment, ventilators, chemical attack response kits, medications, and even federal medical stations, which are essentially pick up and go kits that can establish a mini hospital in a pre-existing building, these consumable resources are only intended to augment the existing medical infrastructure and bolster short-term response needs. Distribution challenges also exist, particularly in a large-scale event where other critical infrastructures like transportation may be impacted, or many facilities may be vying for the same resources. Additionally, national drug shortages for common pharmaceuticals are occurring more frequently, according to the American Society of Health System Pharmacists and the FDA. So with supply chain, cost, and manufacturing challenges, it's not reasonable to expect hospitals to invest in maintaining large stockpiles of potentially expensive and volatile specialized medications for those what-if scenarios. So for these reasons, immediate response with non-pharmaceutical interventions can be the best way to mitigate not just the initial spread of the disease, but the need for sustained response efforts that can further strain and limited medical resources. The graph above demonstrates the impact of community mitigation strategies, which help to delay the peak of the outbreak, minimize the total number of overall cases, and therefore reduce the overall burden to the healthcare system and other infrastructure. The use of this type of intervention was demonstrated throughout the COVID-19 pandemic, and still, as public health officials and government leaders imposed gathering restrictions, business closures, and mask mandates, and promoted good respiratory hygiene practices. While behavioral interventions like encouraging people to wash their hands has very little negative consequence, financially or otherwise, restricting business operation, closing schools, and other such measures can have immediate and sustained economic and social ramifications. All of these factors must be considered when determining the path of response efforts, understanding that infectious disease outbreaks are complex and very interconnected events. Recognizing the potential impact of infectious disease outbreaks to public health and national security, there are several public health agencies and even entities within the Department of Defense that conduct local, national, and global public health surveillance in order to identify potential threats and implement mitigation strategies to minimize spread. The Division of Preparedness and Emerging Infections within the CDC supports the capabilities of the federal, state, and local public health partners to manage infectious disease outbreaks, acts of terrorism, and other emergencies impacting public health. The National Center for Emerging and Zoonotic Infectious Diseases is also part of the CDC and is home of the nation's premier scientists that studies some of the world's most dangerous pathogens, including anthrax, botulism, Ebola, and more. With oversight of the national laboratory networks, including those that support agriculture, veterinary sciences, law enforcement, and quality and safety testing for food and water, this center works to develop guidance and diagnostic testing support for dangerous pathogens. These state and public laboratories handle the most dangerous pathogens of level 3 and level 4 biosafety. The National Center for Medical Intelligence is a component of the Defense Intelligence Agency under the Department of Defense. While medical intelligence gathering within the DoD dates back to the World War II era, the creation of this dedicated agency under its current title took place in 2008. This agency has several branches, all specializing in a component of public health, with the goal of identifying potential threats to the nation's health and safety, assessing our medical capabilities, and protecting national security assets at home and abroad from emerging health threats. So despite our best efforts to monitor and intervene early to manage naturally occurring disease outbreaks, there are some instances where we may face an unexpected outbreak or even an intentional release of a pathogen. Unfortunately, the influence of human behavior on highly infectious disease spread is not limited to the unintentional consequences of population growth, agriculture, urbanization, and research. The potential for an act of terrorism that utilizes a biological agent is very real. As a matter of fact, early in the start of the COVID-19 pandemic, there was discussion surrounding the possibility of it being an intentional release. Further investigation continued as recently as the beginning of this year under President Biden's administration, with the conclusion that the virus was not engineered as a bioweapon, but was still likely released in a laboratory incident. The potential to use naturally occurring diseases as a means of attack and terrorism is not a new concept. Biological warfare has historical precedent, dating back to the Roman Empire, where deceased animals were used to contaminate water sources, the Mongolian Empire, where corpses of plague victims were catapulted over castle walls to infect enemies, and even in the United States, where early settlers distributed smallpox-contaminated blankets to Native American populations with devastating consequences. In recent history, there have been several instances of biological terrorism or intentional release of pathogens into the population. The first case we'll briefly discuss is the Amerithrax case, perpetuated by Dr. Bruce Ivins in the aftermath of the terrorist attacks of September 11th. Letters laced with weaponized anthrax were sent through the U.S. mail to several political and public officials. 17 people were sickened, with 5 dying, making this the deadliest biological attack in U.S. history. The second case involved an outbreak of Shigellosis in a Texas laboratory. Workers were poisoned by a disgruntled employee who inoculated pastries in the break room with Shigella dysenterii cultures from the laboratory, causing 12 people to become ill, some requiring hospitalization. And the final case I'd like to mention is the poisoning of restaurant salad bars by the Rajneesh cult. This religious group lives together on a compound and was hoping to influence the outcome of an upcoming election by sickening constituents so they would not be able to participate in voting. Although no deaths resulted from this attack, this remains the largest scale biological attack in the United States. It is also unique, as this event was perpetuated not as an act of revenge or as a scare tactic, but to influence the outcome of an election. When discussing acts of biological terrorism, it's important to remember that attacks can also be indirect, targeting the agricultural industry, not just the human population. Pathogens intended to destroy crops and sicken herds can impact public health through the elimination of food sources, potential spillover of pathogen creating outbreaks, and significant disruption to the economy. The agricultural industry not only provides food resources for our citizens, but it also represents 13% of the nation's gross domestic product and 15% of all employment opportunities. Because these scenarios have significant public health implications and can cause disruption to the food supply and global trade, the CDC agencies that support public health preparedness and laboratory and diagnostic capabilities recognize the need to integrate an interdisciplinary approach, collaborating with veterinarians, agricultural agencies, and food and water testing facilities to detect emerging diseases and acute outbreaks in livestock and crops, both naturally occurring and man-made. Agroterrorism became more of a focus of homeland security efforts following the terrorist attacks of September 11th, when raids through the caves occupied by Al-Qaeda revealed a collection of documents related to the vulnerabilities of the U.S. agriculture system and training materials related to targeting the agricultural industry. As is true of several critical national infrastructures, the agricultural sector is primarily privately owned and operated, often with little consistency and consideration for security. It is one of the most vulnerable targets to an attack. While it does not have the glamorous appeal of other high-profile potential targets, it is a way to cause significant disruption to several vital national functions. Unlike traditional bioterrorism, agroterrorism often does not require specialty equipment or advanced technology. The ability to use agents that do not infect people is safer for the perpetrator, and often these diseases occur naturally, making it difficult to distinguish an attack from an outbreak. Unlike bioterrorism, where there's a significant social and psychological impact, agroterrorism has more sustained economic impact and can result in food insecurity and disrupt the job market and global trade. History has provided several examples of just how devastating famine can be to a nation and its population. Starvation and disease were rampant during the Irish potato famine when a fungus destroyed potato crops for 7 years in the mid-1800s. This famine resulted in over 1 million deaths, with another million Irish immigrating to new lands in search of better lives for their families. For a more recent example, we look to North Korea in the 1990s. Due to a complex array of economic, political, and social changes, the people of North Korea faced years of starvation, with death tolls estimated anywhere from 500,000 to 3 million people. Unlike the Irish potato famine, which was caused by a disease, this event was the result of financial and political disruption of the country during this time period, something that could be similarly replicated through a naturally occurring or man-made disaster. There's a unique intersection of public health and healthcare providers, emergency responders, and even law enforcement when facing potential acts of biological and agricultural terrorism. This is because outbreak events are increasing in frequency and complexity, making it difficult to differentiate naturally occurring incidents from intentional acts of terrorism. The investigatory process is very rigorous and requires a complex scientific approach, often taking a very long time. Due to the complexity of the situation, there can be some challenges in differentiating. Typically, the agent used and the unique characteristics of that agent would be an indicator that it was potentially perpetrated as opposed to a naturally occurring event. However, we're seeing that illnesses and diseases are evolving naturally in the environment to develop increased virulence or drug resistance. The volume of global trade and travel also has contributed to finding diseases in regions that they typically are not endemic to. And even temporal distribution is not a strong indicator of intentional release as opposed to a naturally occurring event, because we've often seen seasonally associated infections like the flu circulate at atypical times, as was the case with the swine flu pandemic, in which we saw 2 epidemiological spikes of cases in April. Even the point of origin and spread dynamics can be a difficult way of differentiating between natural and intentional outbreaks. There have been several instances where initial cases were identified in multiple locations and in diffuse geographic locations during the beginning of an outbreak, such as the case with the plague outbreak in Madagascar in 2017. Regardless of the origin of the outbreak, there is significant overlap for public health professionals in preparing for and responding to disease outbreaks. Because they cause similar consequences to society, the management of both scenarios requires a similar approach. As was demonstrated most recently in the COVID-19 pandemic, timeliness of response significantly impacts the effectiveness of mitigation and response measures. That timeliness can be supported in a number of ways, including early detection and reporting, collaborative relationships across all levels of public and government health entities, and even the use of artificial intelligence to augment human capabilities in detecting and monitoring potential emerging threats. General public health surveillance is intended to collect, analyze, and interpret information about community health and health concerns to reduce morbidity and mortality of conditions in the population. But when dealing with potential outbreak scenarios, this surveillance can help to identify clusters of cases that exceed the typical background occurrence of this disease. There are challenges in the collaborative efforts of public health entities and direct healthcare providers, and these challenges exist for a number of reasons. Some providers may lack the expertise to recognize an atypical disease, as was demonstrated in the Ebola outbreak of 2014, when a man with a conspicuous travel history and early signs of Ebola virus disease was released from a Texas hospital, only to be readmitted days later and succumb to his illness. Some providers are also unsure of reporting requirements or the process for infectious diseases, even if they are able to appropriately recognize and diagnose them, which is why educational opportunities and collaborative partnerships are great opportunities for all levels of the government and public and private healthcare entities to work together to better identify emerging infectious illnesses and potential patterns in disease outbreak. Traditional surveillance systems are also currently mostly statistic-based, which again, with communication and collaboration challenges and reporting difficulties, presents limitations. With technological advancements, the use of artificial intelligence to augment these human capabilities can significantly benefit not only public health, but other fields that face the challenge of gathering and analyzing large volumes of data. It also enables more accurate modeling for agents and outbreaks, highlighting the impact of various interventions on the outcome of the situation. It's critical that public health professionals effectively manage outbreaks to prevent more global spread and impact. The consequence of highly infectious disease outbreaks range from psychosocial disruption to local and even global economic strain. As we saw in the COVID-19 pandemic, business closures that resulted in job loss, self-outbreaks that impacted production, the screeching halt of tourism and that subsequent income, and supply chain disruption resulted in shortages and reduced global trade. The global economy faced a loss of 3.5% in 2020, which is the deepest recession since World War II, and things have still not returned to normal. From a psychosocial perspective, life as we know it has changed drastically. Social isolation, financial struggle, fear, and redefining common social interactions, such as the shift to remote education and work, proved to be significant stressors to the population. The stress of these rapid adaptations has taken its toll on mental health and has required some redefinition of typical family structure and social roles. Young adults, caregivers, the unemployed, and other vulnerable groups have reported worsening mental health outcomes, increased dependence on drugs and alcohol, and even higher rates of suicidal ideation. So in this way, outbreaks of highly infectious diseases also have very serious secondary public health outcomes. Because public health emergencies are not limited to just the healthcare sector, there's a distinct intersection of public health and homeland security. National security and resiliency are interdependent on a healthy population, strong economy, and continuity of essential operations. Because widespread highly infectious illnesses have the potential to compromise all of these factors, public health contributes to much more than just the healthcare sector. This overlap has been recognized as many infectious diseases and other public health concerns have been identified and addressed by national security authorities, with mitigation and response efforts receiving federal funding and support. For example, military support of response efforts, emergency use authorizations for pharmaceuticals, and funding for supplies, research, and biosurveillance for Zika, COVID, and other diseases demonstrate the overlap and authority of public health and homeland security agencies. Continued movement in this direction will serve to solidify the interdisciplinary approach required to manage highly infectious disease outbreaks. I'll conclude you guys here. I'll stop sharing my screen. I want to leave enough time to answer a few questions here. I do see some things popped up in the chat.
Sorry, I was muted and talking. So thank you so much, Lindsay. So I will start. Hey, JD, did you want me to read yours or do you want to ask it?
I was just curious. I mean, with all the steps that we had to take in 2020, obviously 2021 has gone a whole nother way, but 2020, did the steps we took to combat COVID, did that see a lessening in the overall outbreaks and the, well, yeah.
That's a really great question, because we took a lot of those community mitigation strategies, the social distancing, the mandatory masking, the hand hygiene, and it did have an impact on a lot of illnesses. If you look at our general respiratory kind of garden variety illnesses in 2020, RSV cases, influenza A and B cases, our mitigation strategies for COVID did significantly impact those numbers. We really weren't seeing the number of cases of RSV or influenza last year as we typically do from season to season. And to mention monkeypox just one more time, a big component of public health and tracking emerging infectious diseases is contact tracing for potential exposures when cases are identified. And the fortunate thing was that, again, due to mandatory masking on airplanes, sanitation practices, and measures like that, there really was not a lot of concern that the gentleman who was infected with monkeypox would potentially pass it on to anyone else because those measures were in place.
Okay, so Dr. Langridge sent me a couple questions. He had to jump off. So before I read those, does anybody want to jump in with one? I don't see any hands, so I'll start. So
I was gonna say
ahead,
that, yeah, I was gonna say there's a lot of similarities from what you passed during this past hour in some of the classes, like the class that I'm in with right now with Jen and the other class that I'm in, and just hearing it, it just seems like I just took the entire course within the past hour and now I have everything. So, but it's just interesting to hear because there's a lot of familiar things that I've learned over the past few months.
Yeah, thank you. I appreciate that. And that was something that I found interesting even in my studies when I shifted from my nursing background and clinical to homeland security and emergency preparedness, is that things really interconnect much more than you realize until you start to dive into the content and you go, oh, well, public health impacts homeland security and national resiliency and different infrastructures, and you find a lot of interconnectedness, which is neat.
Yeah, I've got a military background, and a lot of those things that you were mentioning in your brief, I've had a lot of experience with, like the stockpile of medications for the just in case situation, where you have, anti-nerve agent medication, like 2-PM chloride, you had to maintain that stuff just in case something like that pops up. Or you're talking about the wet markets. I was down in Southeast Asia and also over in Korea for a few deployments, and I was able to witness some of those things and actually partook in some of the finer delicacies, so to speak.
Good thing the military gives you a lot of vaccines before you go.
Yeah, my arm still hurts.
I did read my husband part of your discussion post when you were talking about the green salsa that turned out to be whatever animal bile that was. That
Yeah, that was interesting because we were over in Laos. We were doing recovery missions, looking for servicemen who didn't make it home from the Vietnam War. And we were at a F4 crash site from the 1970s. And, we were looking for his remains, and we found him, so he's able to, return him home. But we had a little picnic where they, the villagers took us out into the wilderness, it must have been like a 2-hour drive, and found this nice, beautiful place to go swimming in. And they cooked us this, like a barbecue. And I had, it was beef. It was some sort of cattle. I don't know exactly what, maybe water buffalo. I don't know. And they were serving it to us. And, I was watching them eat, with me being medical, I had to make sure that everybody was eating safely, because I didn't want to treat anybody for any type of illnesses and things like that. But they were dipping this stuff, the meat, into this green liquid with peppers and onions and all this other stuff. I'm like, you know what? I'm going to try it too. Took a bite of it, and it tasted like a barn. It was basically, it was bile, fresh bile from that cow. And it was not too pleasant.
That post is going to stay with me for a while. That post is one of the more memorable ones I have gotten. So one of our questions from Dr. Lengrich was, what has surprised you in your new role at Hershey Med?
That's a great question. So, I had worked at a large healthcare network previously, but I really focused my efforts on the satellite campuses in the northern tier. So they were much smaller community hospitals. So their level of preparedness compared to the level of preparedness for an organization that serves such a large community, that offers so many specialties, that holds this, designation as an Ebola treatment center, the level of preparedness really surprised me in a great way. It was fantastic to come and see all of these plans laid out, all of this equipment, all of the things that they have access to, because your average healthcare facility doesn't have access to that technology, to that space, to that infrastructure, or even to that education and that training. So that was definitely a surprise of coming here, and one that I was very happy to be surprised with.
It's always good to have pleasant surprises.
Yeah.
Lindsay, you work for Penn State Health?
Yes, I work for Penn State Health. Yep.
Where do you work at? Because I work for Penn State Health.
Oh, I work at the Milton S. Hershey campus. I actually am in the Eastmore building.
Okay.
So I'm off the main campus.
Okay, I'm actually moving over to the new Hampton Center next week. I'm picking up a new role in the safety department. So I'll be over there. I'm actually right now working. I've got 2 clinics in Harrisburg and Mechanicsburg. I manage 2 of them, and I took a new role starting next Monday.
Oh, well, welcome. And I'm sure I will be working with you then in some capacity, since you'll be at Hampton.
Yep.
So he had 2 kind of follow-up questions on that. Next one was, what challenges do you see for your next year in that role?
So that's another good question. The biggest challenge that I see right now is that it's really hard to refocus folks on other emerging threats, other illnesses, other things that we need to be prepared for, because unfortunately, we're 2 years into it and we're still in the trenches of COVID. So, we're still seeing that staff burnout. We're still not getting that break. We're still experiencing supply and distribution issues. So I think that the will has been worn down for a lot of folks, and kind of getting that re-engagement and reinvigorating them into looking forward to, the next COVID. Nobody wants to look to the next COVID. Nobody wants to think about the current COVID. So I think that's probably going to be a challenge.
Yeah, it's interesting how many people are like, this just needs to be done. It's like, well, it doesn't actually work like that.
I find myself even talking about it in the past tense, and then I have to correct myself because it's not in the past yet.
Yeah. He also wanted to know, what role do you play in the emergency plan at the medical center?
So the Ebola operations plan is actually its own document within the hospital's entire EOP. So I am responsible for the oversight of that document, the supplies, the education and training to keep the staff up to par, and any additions or evolutions that need to be made in pandemic-related kind of policies and emergency operating procedures.
Okay, great. So does anybody else have any questions? You can type them, you can raise your hand.
I think I talked everybody out. I appreciate everybody being patient.
No, I think it's more like that was so much great information that you kind of preempted and answered them all.
You were incredibly thorough.
Painfully thorough.
No, never. No, that was great. I appreciate you taking your time and talking with us tonight. So I don't see any hands. So thank you so much for coming and speaking with us. Again, we really appreciate it. This was great. And for everybody else, we will see you on February 2nd if we don't see you at the IAEM meeting before. And best of luck finishing up your semester. Happy Hanukkah if you celebrate. Merry Christmas. Happy New Year. It's crazy that we're saying all these things already. But have a great night. And Kelly said, thank you. Great presentation.
Thanks, Kelly.
So thank you everybody for coming, and I'll be sharing the link so that way you can rewatch it if you want.